So I have several questions. First, it is very important that we find the fat metaplasia in MRI is a very crucial phase, and it is just between the inflammation and also the inflammation that is like the bone marrow edema and the new structure damage. So it's the intermediate state. So in your opinion, in which clinical or image scenarios should we recommend some active target therapy for the patient just with the fat metaplasia?
Yes. So if the patient, as you've well outlined, where fatty metaplasia lies in the evolution of the pathogenic lesion in axial spondyloarthritis, and it is part of the disease pathogenesis and marker. And if we see fat metaplasia, we treat it just in the same way as we do with T2 stir light up. And that is, we consider that to be evidence of active inflammation and worthy of very active treatment. So we will certainly want to try the medicines that I've indicated are most effective in halting this type of progression, and that's TNF inhibitors, JAK inhibitors, and IL-17 inhibitors.
Thank you. So which kind of drug do you prefer, or just they are same?
It depends. So in some instances, we are pushed by our insurance companies in the US to use a TNF biosimilar because it's less expensive for them. But aside from that, we find that the efficacy data with all three medication mechanisms is similar. And so I don't have any problem with starting with a TNF inhibitor or an IL-17 inhibitor. As I mentioned, in the US, we often need to start with a TNF inhibitor before we can use a JAK inhibitor. There are certain circumstances where we need to be more specific. For example, if the patient has concomitant inflammatory bowel disease, we will not use an IL-17 inhibitor. And that's a situation where JAK inhibition is proven to be very, very effective, as well as the TNF inhibition class. And uveitis, we will favor using a monoclonal TNF antibody in that circumstance.
Yeah, thank you. So the second question, I'm very interested in the new drugs you introduced to us. Since the TL1A inhibitor have demonstrated as not only the anti-inflammation but also anti-fibrosis potential, so can we also inhibit the spinal bony ankylosis or the fibrosis fusion in AS patient, and can we use it to prevent the radiographic progression? Do you think that drug have the advantage over other drugs in this aspect?
So this is one area where I'm going to have to say I don't know yet, simply because we're in the very early stages of seeing how effective this class of medications can be. First of all, in treating inflammation, and then second, in preventing fibrotic tissue changes. I think we have, based on some pretty successful inflammatory bowel disease trials, we have optimism, but we just need more data, and we're just in the beginning stages of trials, at least in our center.
Okay, thank you for your comments. And last one, I know that the GLP-1 is very hot this year, and you also introduced the Together PSA study. So do you think the GLP-1 or GIP can reduce the inflammation in the patient, especially in the very early PSA or the PSO, to prevent the patient progress to PSA?
So I happen to be in the camp that does believe that can be the case. When I give a full lecture on obesity management, I share a case example of a patient who had active psoriatic arthritis and psoriasis, who had tried a TNF inhibitor, had good response, but then lost response, tried an IL-17 inhibitor, then lost response, and then went on GLP-1 receptor agonist alone and had a very significant response with improvements in the joint scores, the PASI score, the CRP, and so forth, along with about a significant amount of weight loss. And so, and in practice, we've now seen patients who have had a certain level of improvement with their immunomodulatory drug, enough for them to be okay with continuing it and not wanting to switch, but not perfect. And then with addition of a GLP-1 receptor agonist, they've sort of gotten over that threshold into being even more um, uh, happy with their outcomes, with less pain, less stiffness, less fatigue. Now, we don't fully understand how that's happening, and it could be that some of it is psychological, because if the patient has better self-esteem with lower weight, they're able to do more exercise because of lower weight, and so on. There can be multiple factors playing into their feeling of improvement. But we've seen some really nice outcomes in that regard. I don't want to be too Pollyannish, because we have to watch for things like sarcopenia, muscle wasting, if you go too far with a GLP-1 receptor agonist. There are the background issues of nausea, constipation, or diarrhea that can happen, and it's expensive. At least in the US, it's expensive. So these are all issues that balance out the really positives. But as more and more of these compounds are introduced, as the costs come down, and they're used to promote a healthier lifestyle in general, I think the balance is in the positive direction for their use.
Okay, thank you, Professor Philip, for your wonderful presentation and your sharing. Thank you. I learned a lot.
I will like to comment, Professor Chung, that I see a couple of the questions in front of us, and I do feel pretty strongly about the concept of treating to target. We use as a target for treatment in psoriatic arthritis, we use either minimal disease activity criteria or the DAPSA criteria, or both, in trying to achieve low disease activity and remission. And patients like that. Where I work in Seattle, we have a lot of people from the tech industry that come to see us as patients, and they come in with their spreadsheets with MDA being tracked or DAPSA being tracked. And similarly with axSpA, we like the ASDAS threshold of 2.1 or less. So I'm a great believer that getting to a target of low disease activity is going to have lots of benefits for the patient.